Okay, guys, in 20 minutes, I'm going to give you an overview of acute aortic dissection. Uh, One of the leaders in cardiovascular surgery was Michael DeBakey, and he was very instrumental. He did the first replacement with Dr. Cooley of an ascending aorta for acute dissection. He also did the first replacement of the transverse aorta. And so his contributions are tremendous. Also, created a synthetic vascular graft, similar to what we use today. Oh, and importantly, he was 99 and had an acute aortic dissection. And he was operated on by one of his colleagues and stayed in the hospital quite a long time, but he recovered reasonably well, long enough to shake hands with Denton Cooley, his arch rival, for 50 years. Dissection really means tear in the aorta. Aneurysm means dilation, and the definition of aneurysm is often considered to be 2 times normal diameter or 1.5 times normal diameter. So patients come in very alarmed by that word, aneurysm, but I have to calm them down and say it just means a dilation. It's a definition, and use 1.5 or 2 times diameter. And I would point out that all these are kind of related because a dissection can end up as an aneurysm. An injury, an iatrogenic injury with a cannula or catheter can cause a dissection. And sometimes the words are used together, dissecting aneurysm. I try to avoid that, just use dissection or aneurysm. The triple rule out with somebody with chest pain is a CT scan, rule out embolus, pulmonary embolus dissection, and possibly acute coronary syndrome with enzymes. But acute chest pain that's the main symptom for acute aortic dissection. When I'm called about an aortic dissection, and the way it's structured now is that 2 weeks a month, this Baylor takes aortic dissections for the system, and 2 weeks a month, Plano does. So we'll get a call from the transfer center, aortic dissection coming in. And I'm interested in several things. When the patient gets there and looking at the CAT scan, I want to know the chronology. Is it acute, subacute, chronic? If you don't treat a type A or proximal dissection within 48 hours, half of those patients are dead. So a proximal or type A dissection is a very lethal condition and 50% mortality within 48 hours. I want to know how far it goes. Is it just ascending or transverse or descending or abdominal? Is there an entry or exit tear that's visible by CT? Usually it's very difficult to tell, but we try to tell anyway. Is there a malperfusion syndrome? Is there an acute MI from a torn right coronary? Is there a stroke? Is there acute renal failure? Is there abdominal pain with mesenteric ischemia? Is the patient suddenly paraplegic? Is one limb malperfused? So we want to determine if the patient has malperfusion. Then I particularly examine the arch vessels on the CAT scan. Is the innominate, left carotid, and left subclavian involved? Because that helps me understand sort of cannulation techniques to go on the heart-lung machine. And then I look at diameters. Then I look at the aortic valve area and determine if the aortic valve needs to be replaced. And then we try to determine if the patient has a connective tissue disorder like Marfan's, and whether the patient has a bicuspid aortic valve. And we'll get to that later, but bicuspid aortic valve means 2 leaflets on the aortic valve instead of 3, and 1 to 2% of the population has a bicuspid aortic valve. And there's a condition now we're calling bicuspid aortopathy, meaning the aorta is abnormal associated with a bicuspid aortic valve. Okay, so this is just got a thing here. Okay, this is the DeBakey classification. That's a type 1, which goes all the way around the horn. Think of it as a candy cane, and it involves the whole candy cane, or at least ascending and descending. A type 2 in the DeBakey ends at the innominate artery. In other words, and I would also point out that the pericardium ends right there. So a rupture in this ascending aorta produces immediate cardiac tamponade. Most people think maybe the sac ends at the top of the heart. The pericardial sac ends right up there. So a tear there produces sudden pericardial tamponade. And this is a type B, or excuse me, a type 3 in the DeBakey. But now most people use the Stanford classification. And that's a type A, and that would be a type A. Both of these are type A. Anything involving the ascending aorta is a type A, and the descending is type B. So most people have abandoned the DeBakey classification and instead use the Stanford, which combines these two right here. Now, these two are emergencies. Anytime it involves the proximal aorta, it's an emergency. And if it involves just the descending, it's not necessarily an emergency. So as I said, the type 1, type 2 and the DeBakey are operated on immediately. Type 3 is not. And in the Stanford classification, which is a little more simplistic, type A is operated on and type B is historically is not. It's treated medically. The classifications are really inadequate in some ways in that they don't tell you about the tear. They just tell you where the dissection is, the longitudinal dissection. In other words, you could have a tear in the descending aorta, which goes antegrade down the aorta, but also retrogradely to the aortic valve. And that would be a case of a tear in the descending aorta, but involvement of the proximal aorta, and so that would be a type A. So the Stanford classification and the DeBakey classification, they don't take into account, it's a very simplistic kind of category because it does not involve the tear. It's a very underdiagnosed condition. This was just a paper from this institution which pointed out that there's a huge, let's see, it says autopsy rate today is low. The percentage not diagnosed clinically is about 23%. So a lot of people die with a dissection or die from something else and had a dissection, and it was clinically silent during life, surprisingly. This is a heart, and that's the left ventricle in a hypertrophied heart. Okay, see how thick that muscle is? Everybody with aortic dissection has severe systemic hypertension. And that's what the heart looks like in hypertension. It's very thick, and that's left ventricular hypertrophy. And most patients that I've seen that come into the ER with aortic dissection have a systolic blood pressure of 180 or above. And it's just a violent pressure and a violent tear in that aorta. And it produces horrible chest pain. But they often will say, well, I stopped taking my blood pressure medicines. Or, I haven't been back to the doctor in a while. And their systolic blood pressure is, 210. Most people, believe it or not, this is a cross-section of the aorta. Most people, believe it or not, that have aortic dissection have a normal aorta histologically. It's been thought that it's been abnormal, and these are the elastic lamina in the aorta. And 4 out of 5 cases of aortic dissection, it's actually normal histologically, the aorta. These are loss of elastic lamina. And 1 out of 5 cases, you find that. So the histology of the aorta is not necessarily going to help us here. Where does the tear occur? People often say it's in the intima, but it's really, the aortic wall has 3 layers. A an intima, a media, and an adventitia. And the tear, if this is the lumen up here, the tear occurs in the media, which is the middle layer. And it tends to, now, if you look at this and you've got a tear there, where do you think, and this is the entry, where do you think the exit's going to be? Do you think it's going to go back that way, or do you think it's going to go out this way? More than likely, it's going to be an external rupture because the media is only 1/3 there, whereas it's 2/3 or more there. So the tear and dissection occurs generally in the outer third of the media. So external rupture, is more likely. When we open the chest and look at an ascending aorta that's been dissected, it is so thin. It's like paper. You can almost see the blood through it. And you realize why their mortality is 50% at 48 hours, because it's a very thin aorta at the dissected spot. There's a familial component to this. This is a family that had a dissection in two family members. The genetics, we're all working on, and we're going to start a genetics program here investigating genetic aspects. This was dissection in two different family members. This person had an old type B and a brand new type A, and the son had an acute type A. So I always ask the patients about, anybody in your family ever have an aortic dissection? This is a long list of the complications of dissection, which I won't go into. We'll just look at these pictures, and that'll give you a good idea of what we're talking about here. A type A aortic dissection, as I mentioned, that's the aortic valve right there. And the ascending aorta is this right here. And as I mentioned, the pericardial sac goes all the way up to the innominate artery and encircles the heart plus the ascending aorta. So if you get a rupture, which is what happened here, you get a rupture, boom, right there, it's going to fill the sac and the patient dies. And that's why a proximal ascending aortic dissection has to be treated. And we just put a graft, a polyester, a synthetic graft, and just replace that ascending aorta so it doesn't become a problem. It's really ghastly when you open the chest and look at a dissection. It kind of looks like this, purple, blue, and the adventitia of the pulmonary artery and the aorta are shared. So sometimes you see hemorrhage over the pulmonary artery as well as the ascending aorta. And was simply a case of there was so much adventitial on the pulmonary artery that it compressed it. This is what we mean. This is a cross-section of an aorta, and this is what we mean by true channel, false channel. And this is a case of the false channel is filled with thrombus, and it's pushing down the true channel. Sometimes in the CAT scan will show us this by cross-section, just like this, and it'll show, let's say, the descending aorta, where the true channel is amazingly compressed, and it's almost flat, and it's compressed by the false channel. So a dissection is a tear which creates two channels, and the surgery is meant to put all the blood into the true channel and exclude the false channel. When we sew a graft into the ascending aorta, we eliminate that false channel. That's what we're trying to do. This is the arch vessels, just a cross-section of the arch vessels, and that's the innominate artery, and that's the left common carotid and left subclavian. And when you get a dissection going up that innominate artery, you see, it can compress it. And people, let's say it went up that artery, it can cause a stroke. The importance of, this is a patient with a type B. It began there and went down. And this is what it looks like say 10 years later. And that is why anybody that has an aortic dissection requires surveillance down the line. Like if somebody has a type B, they go home, they're doing well, I'll see them back in 6 months with a repeat CAT scan because we're following to see if this becomes aneurysmal and whether we need to put a stent graft in there. If this is, as I said before, this would be a case of somebody who had a dissection and now has a aneurysm. We may go to MRIs contemplating that for the surveillance. Okay. Now, this is a case of if you have blood pressure control after a dissection is very important. Somebody could come to the hospital, have a type B like that, no surgery done, they go home. If the blood pressure is not controlled over the years, they can come back with a type A. So medication for aortic dissection is typically a beta blocker, and it's called anti-impulse therapy. You're decreasing the impulse on that aorta. But everybody with a dissection for practical purposes requires a beta blocker. When you have one condition, like an abdominal aortic aneurysm, the frequency of another aortic condition is higher. Somebody has a history of a AAA, their risk of an aortic dissection is actually higher. This was a patient that started with a AAA, and then he had a type B, which healed, and he later died of a type A with a rupture. So the aortic conditions seem to, they occur with higher frequency together. Now, I pointed out that half of patients with a type A, that's ascending, untreated, are dead at 48 hours. And 75% are dead within 2 weeks, if untreated. But there are the rare patient that can heal a type A. It can happen. But in general, this is the principle. Type A, which means proximal aorta, requires an emergency operation. Type Bs, historically, if they're uncomplicated, meaning no malperfusion, no limb problems, no mesenteric problems, no aneurysm, they can be treated with beta blockers. And that's kind of how the thinking has been historically. If they're uncomplicated medical management, if they're complicated surgical management, and that now involves TVAR, thoracic endovascular aneurysm repair with an endograft. And because the endografts are much easier to place now, our threshold to put them in a type B has lowered. I'm going to say a couple words about aneurysms because there is some overlap there. When somebody has an aneurysm, we'll call it 2 times abnormal, symptomatic or asymptomatic, chronic, acute, intact, ruptured, true or false. That means all 3 layers of the aortic wall, and that means not all 3 layers. So an acute dissection that 5 years later is dilated is really a false aneurysm. Most AAAs are fusiform aneurysms. It can be central or peripheral. The concept that aortic dissection occurs because of a large diameter has been in place in medicine for several decades. And the general guideline is if an ascending aorta is over 5.5 centimeters, it should be replaced. I put the female category in there. There's really no index to this. Abdominal aorta, internationally, it's 5.5, but most places, including the United States, aneurysms are treated at 5.0. But in England, it's 5.5. 5.5 is the key number to remember. However, if someone has these other conditions, Marfan's, connective tissue disorder, family history, bicuspid or unicuspid aortic valve, 1% of the population, rapid expansion, severe aortic problems, associated cardiac surgery necessary, then we may permit ourselves to come down to 5.0 as the threshold. So when I get a random CAT scan from the ER and a call, somebody's got a dilated aorta, they come to my office, I'll immediately get an echo to see if they've got a bicuspid aortic valve. And then kind of go from there and take a good history, because I'm trying to determine whether I should go with 5.5 or 5.0. This is a case of bicuspid aortic valve, rupture. All these conditions are sort of LV outflow tract bicuspid aortopathies, and they all occur with increasing frequency together. That's the aortic valve, but if you have a bicuspid, that's a trileaflet aortic valve with calcium on it, and that's a bicuspid aortic valve. But if you have that, you've got to watch out for aortopathy. And one of the ways people would bring down the size of the aorta was simply remove a section of it and make it smaller. These are coming out very well, but that's a very big dilated aorta, and we removed a part of it and with long felt strips made it smaller. That's called a reduction aortoplasty. If you have somebody with an old aortic valve replacement, that's a Starr Edwards, it's very old, they can come back with a dissection if that valve was a bicuspid valve. So people that have a bicuspid aortic valve kind of need to be followed for their aorta. And there's some people, this is Cleveland Clinic study, bicuspid aortic valve surgery with proactive ascending aortic repair, and they use 4.5 as the cutoff. And what's the point of all that? It's to avoid aortic dissection. Why would you replace an ascending aorta prophylactically? It's to avoid aortic dissection. So, in summary, thoracic aortic emergency operations would be indicated in any kind of rupture of the thoracic aorta. Ascending would be treated by open and descending probably by endograft. Any type A, and that means it involves the ascending aorta, and any type B with any sort of complication. We haven't really talked about transection, but that occurs in the proximal part of the descending thoracic aorta where it's tethered. And with an automobile accident, it does like that because it's tethered where the PDA was. And now the ligamentum arteriosum is, and it's fixed there. So when you have an acceleration, deceleration injury, it's like that. And it ruptures that aorta right there. And it's treated by endograft now. It's very quick. It takes 45 minutes, drop in the endograft. So I think I'll close right there, and if you have any time for questions. Okay, fair enough.
All right.